Okay, we are all ready. Okay, good morning, Canada. Thank you so much for joining our educational webinar. Meet the Expert with Professor Michal Beeri from Sheba Medical Center, Tel HaShomer. My name is Einat Inbar, and I'm Executive Director of Canadian Friends of Sheba Medical Center. A bit of background on Sheba for all of our new friends joining us today. Sheba Medical Center has been ranked among the top 10 best hospitals in the world by Newsweek magazine for 2 consecutive years. Wow. Sheba is the largest and most comprehensive medical center in Israel and in the Middle East. It is also known for its leading cutting-edge research, educational training, innovation, and compassionate care. Something very important to know is that Sheba was born alongside Israel in 1948 and serves as the Israeli City of Health. Our volunteer-based group in Canada is dedicated to raising awareness and funds to support the world-leading organization. For decades, Sheba has provided pioneering, life-saving treatments to patients in Israel and around the world, creating bridges of peace and sending humanitarian missions to save lives around the globe. Canadian Friends of Sheba teamed up with a few partners to make today's event so successful. I would like to thank them. First, to Miki Nachmani and David Baskin from Baskin Wealth Management, and to their clients for joining today. Andrea Diam from Schwartz Reisman Center in GTA, Toronto. And our loyal community in Montreal, the Spanish and Portuguese Synagogue, great partners for more than a year. And I have a story to share with you. Someone told me once, if you don't ask, they will not give. Today we offer this webinar for free. And so I ask you, if you can give and support our cause, please consider doing so. Every contribution, big or small, goes a long way. Thank you so much for joining today and for your support. We'll watch a very quick video before we start.
Only those who know how the day starts, but not how it ends. Who tried, succeeded, then tried again. Those who worried. Those who did not give up. Those who felt the weight of responsibility on their shoulders. Only those who saw the end and realized it was only the beginning. Who brought new life into the world. Who've tasted victory. Those who constantly seek out the next discovery. Those who believed. Only those who slept 2 hours a night. Who removed all social barriers. Who kept their cool. Those who dared, supported, protected, laughed, made others laugh, pioneered. Only those who broke new ground, who wake up every morning to carve a new path. Only they understand. Hope has no boundaries. Sheba Tel HaShomer, City of Health.
Good morning, everybody. My name is Daryl Reitman. I'm the chair of the board of Canadian Friends of Sheba Medical Center. And I'm very pleased to introduce and welcome Professor Michal Beeri from Sheba Medical Center. So just a few words about her. Professor Beeri is the director of the Joseph Sagal Center for Neuroscience Research at Sheba Medical Center. And she's also professor of psychiatry at the Econ School of Medicine at Mount Sinai in New York since 2001. She studied at Bar-Ilan University, where she obtained her PhD in rehabilitation psychology in 2000. Now, a few interesting facts about Professor Beeri. She's world-renowned expert in the brain. She's been continuously funded by the National Institute of Health since 2003. And specializing in geriatric psychology, her career has been fully devoted to the study of cognitive impairment, Alzheimer's disease, and dementia. A major focus of her work has been diabetes as a risk factor for dementia and Alzheimer's disease. Her studies focus on lifestyle, blood, and genetic factors affecting the greater brain and cognitive impairment of diabetic individuals. Dr. Beeri's other major scientific focus is the neuropsychological and neurobiological aspects of cognition in the oldest old. She has over 100 peer-reviewed publications and numerous prestigious awards, including the Young Investigator Award of Research Excellence at Mount Sinai and Distinguished Reviewer Award from the American Diabetes Association. We're going to have her come on in just one moment and share with us her knowledge about the brain. If people have questions, I'm going to ask that you put it in the chat, and at the end we'll have a Q&A session, and I'll be collecting some of those questions and posing them to Dr. Beeri. So without any further ado, Professor Michal Beeri, welcome.
Thank you so much. Let me just see if I can share this. Can you all see it?
Yes.
Yeah, see it well. Yeah, let me just make sure that this is the correct draft. Yes, it looks like it. And when people say here are some interesting anecdotes about someone, in this case me, then I think you're going to say things like, she can't live without chocolate, or she can dance Zumba for 6 hours in a row. But we'll we'll stick to the number of papers and publications and whatever. In any case, and I know more soccer than any man. That's the most important one. I know soccer more than any man. Now I'll begin. What I'm going to try, it's going to be intense. I believe we have close to 200 people watching. So I know no matter what I do and try to, in this intensity of information, to bring the maximum amount of information, and hopefully will answer many of your questions. I'm sure it won't answer all of them. So I'm saying a priori that my intention will be to give an overview about the disease, its risk factors, where the literature is today in terms of treatment and prevention, and the directions that we at Sheba are taking and hoping that we'll be able to make a significant difference in preventing this disease. Yeah, it would be nice if this, oh, here we go, or not. Let's try again. So someone else is sharing now, not me. Again.
Now it's yours. Yeah.
Yeah, I know. Thing is that when I'm trying to move it, it's not really cooperating with me. Let's try again. I'm going to stop sharing, close the file, open the file, and try again. So I apologize, but something is not working. Escape. And I'll bring it up again. Sorry, guys. Yeah. In case, maybe because it's too heavy, I'm not being able to move it on. Maybe I'll ask you to try, and then I'll keep saying next slide, which is less fun than me doing it by myself, but just so we don't hold everybody waiting. So I'm going to give it one more try, okay? Let's see.
You're okay now?
Yeah, here we go. Okay, thank you. There you go. I don't know what was the issue, but here we are. So if I was face to face with you, I would enjoy much more what I'm going to do now, but try to be honest with yourselves and indirectly with me with regard to my questions, okay? I can't see you all, but would you, if there is anybody that never forgets names, please write to me on the chat on the side, because I want to believe that. But the point that I'm making is that the vast majority of people after the age of 40 have instances that go and become more prevalent of forgetting names, okay? And in contrast, in Alzheimer's disease is something deeper, is forgetting not only the names, but also who the person really is and how that person is related to you. And the reason why I'm bringing this up is not too long ago, I gave a presentation on a Saturday morning, and actually was with Yair Lapid. He was first, I was second, so I was sure everybody would leave after he left, but actually they were all very attentive. And of those 800 people that were watching the presentation, one raised his hand and said, I always remember names. I did not really believe him, but maybe there is someone like this in the world. And what this means is that forgetting names is the norm, okay? When something happens in 799 people out of 800, it means that's the norm. It is an annoying norm, it's anxiety provoking, makes us feel uncomfortable, it's embarrassing at situations, but it is not deterioration. It's not something that we should be concerned with. The same thing with forgetting the date of a party. Okay, so if we remember in general that it was a bar mitzvah last year in July, that is fine, right? If we don't remember that it was July 11th at 2 o'clock in the afternoon, that's not important. And in a patient that is developing the disease, it's deeper, okay? The patient might not remember he or she were in the party, who the party was for, etc. And if I ask you all the same question about names with regard to keys, if anybody has never forgets where they put their keys, sometimes people raise their hands in a situation like this because if you put your key every day at exactly at the same place, then there won't be a problem. We'll know where the keys are. But the reality is that this is not important. It's very common to forget where we put our keys, where we put our glasses, and so on. And in contrast, in a process, in a neurodegenerative process of the Alzheimer's side, in the more advanced stage of the disease, you can see a patient coming with a key to the door, knowing that that key has something to do with the door, but not being sure what that connection is. Okay, so my point is there is something in the breakdown of the cognitive process that is much deeper than not remembering if you put the key at the entrance of the house or in your bag. With regard to learning new things, if I was face to face with you, which I've mostly preferred, I would have asked you if older people, 100 years old, I'm taking to the extreme, if 100 years old people are able to learn. And the answer is yes. No matter at what age we are, we can learn new information. It's true that when we're younger, we learn it faster than when we're older. We learn larger quantities than when we're older, but learning process does not stop. And we make good use of it clinically. And I'll give you an example, okay? I'm gonna pick two imaginary people. Let's pretend they're men, and both of them are 78 years old. Both of them are engineers, both of them highly educated, and both of them coming with the same complaint, okay? Both of them say, I'm scared I'm developing Alzheimer's disease because I feel that my memory is failing. We take the first person and we test that person for a gazillion things, but I'm gonna give you one example of kind of testing that we do. We give the person a list of words, let's say 10 words, and ask the person to remember as many words as they can. And they remember five, that first man remembers 5 words. Then we give the same list once again, the person remembers 7 words. And we give it for the third time, the person remembers 9 words. That 579 is called a learning curve, and it's precisely what I want to see. All right. In a very, very old person, we'll see 1, 2, and 3, but we still see that little improvement over time or over repetition. We take the second man in, and I remember same level of education, same gender, same age, same complaint, same profession. And that second person comes in, and for the first time we read the list, he also remembers 5 words, just like the first one. The second time he remembers 4 words. The third time he remembers 5 words again. That person does not seem to be learning, all right? And that's a red light for us. So this shows you that we can make good use of learning as a tool for how much that person is being able to retain new information. In Alzheimer's disease, the capacity of learning new material goes away. And finally, something that embarrasses all of us, it goes in 2 levels. One of them is something you wanted to say. You call a friend, you want to say something and say, darn it, I can't remember what I wanted to say, I'll call you later. Or most times you go to the room, you want to look for something, you have no idea what you came to look for, to the kitchen. I think most often people go to the kitchen and can't remember what they wanted in the kitchen. All of us have it, okay? It's common. Most of the time, 2 hours later, the day after, 2 days later, you remember, damn, this is what I wanted, okay? When that happens, we're fine. There was a problem in approaching and retrieving that piece of memory. Something bothered it from coming out. But as soon as it came out, we're in good shape. And in Alzheimer's disease, there is no remembering. Okay, you forget and it doesn't come back. So how do we diagnose Alzheimer's disease? Generally speaking, it is a disease of memory. And this is what most people know, that Alzheimer's disease is a disease of memory. But we need to see, by the way, I should make it clear, it has to be an objective impairment of memory. We have to test it. Because many, many people, just like the examples that I just gave you, many people have a subjective memory complaint. They are afraid they're forgetting, or because they forget names, they're sure that the disease is coming. It has to be an objective impairment of memory that we test, all right? And then we want to see at least one more cognitive domain that is impaired. And it could be orientation in space, orientation in time, executive functions, the capacity to make decisions, the capacity to understand sense of humor, the capacity to be flexible in your thought process, all right? All those slowly become impaired with the disease. By the way, many times people come and say, patients, right? Caregivers say, not patients, caregivers say, he can't even make a decision of what he wants for breakfast. And the decision-making is a particular region of the brain that is eventually affected by the pathology of the disease, and the person cannot make a decision anymore. We also want to see a clear deterioration compared to the original state. That is an important point, okay? At Sinai, we used to have a patient who was 94 years old. She was quite remarkable. She was incredible. She had pumps like this. She had zero balance, but she had to wear very high heels, red, because a woman has to continue pretty for the rest of her life. And that woman continued driving. And one day she came late because she got lost. And I got a little nervous. And we tried to tease it out. And that woman had terrible orientation in space all her life. It had nothing to do with a deterioration state. Typically, the families will say things like, you have no idea who she was. If you only knew how intelligent he was. Things that make you understand that compared to a prior state, there was a change. Then we also want to see that there is a clear impairment in social, professional, and day-to-day functions, okay? And the professional thing is actually quite interesting because if, let's say 15 years ago, a woman stopped working at the age of 60 and a man at the age of 65, we know already that's irrelevant and that people tend to continue working until, many of them until their death, right? And we have a family of 4 siblings that the oldest is 103, then 101, 99, and 98. And the 98 years old guy, he is a lawyer who works with his son, grandson, and great-great-son, everybody in the same company. So today actually happens that if in the past, a family member would be the first one saying, wait a minute, something is happening. Today, many times, coworkers and people who work with that person can say he used to be very neat and now his desk is a mess, or he has been forgetting meetings. Things that come from a broader, let's say, milieu of people that are exposed to that person who is deteriorating, which is a good thing in many ways, because sometimes we catch it earlier. And finally, we want to make sure that it's not something else, right? We want to make a differential diagnosis. We want to know that it's not a tumor in the brain, that it's not stroke, that it's not a severe vitamin B12 deficiency, that it's not severe depression. The greatest risk factor for Alzheimer's disease, wait a second, even though I'm not in front of you, I'm beginning to get warm. So as Joe Cocker says, you can leave your hat on. Here we go. Einat, can you see my mouse? Because if you can see it, others can see it as well.
Yes, we
do. So between the ages of 65 and 70, 4 or 5% of the people will have some kind of dementia. And let me take 1 minute to explain that, because that's very important. People get confused between dementia and Alzheimer's disease. Dementia is an umbrella name for many types of diseases that look similar to Alzheimer's disease. In other words, a deterioration of cognitive capacity. But there are different pathologies in the brain that cause those different types of dementia. If we take 100 people who have dementia, 70% of them will have Alzheimer's disease pathology in their brain. And the other 30% will have some other kinds of dementia, like vascular dementia, which is disease of the vessels of the brain, and Parkinson's disease-related dementia, AIDS-related dementia, and so on. The reason why people get confused between Alzheimer's and dementia is because the vast majority of the cases of dementia are Alzheimer's disease. Yeah, so here we're looking, when we look at the full length of a bar, it means dementia in general, okay, not Alzheimer's disease specifically. So it's between the age of 65 and 70, about 5% of the people have primarily Alzheimer's disease, but in general, some type of dementia. If you jump to the 85 to 89 years old, it's about half. Think of what I'm saying now, okay? The fastest growing segment of the population in the developed world, i.e. those above the age of 85, half of them will have dementia of some kind. Now, we had the hopes in the past that if you kind of make it to 90, then you're so strong, you have strong genes that made you survive it, then you probably won't have dementia and Alzheimer's disease at older ages. And the reality, unfortunately, that is not true. And theoretically speaking, if we go to 125, and we know we'll get there because the longevity continues going up, then theoretically, I'm emphasizing theoretically, we'll all have some type of dementia. I don't want to be so depressing, and I'll contradict myself later on, but this slide is mainly to emphasize to you what is the size of the public health disaster if people like me and my colleagues don't find a solution for this disease. And obviously that is our greatest motivator. So now I'm going to try to walk you through a little bit of what's happening in our world now. And a few depressing slides, but I swear to God, we'll get to exciting things as I progress, all right? So there are over 460 molecules that have been tested in the last 10 to 12 years. Medications, okay? 460 types of medications that have been tried in clinical trials and failed, all right? None worked. Now, when something like this happens, we as scientists must ask ourselves, what is that we're doing wrong? How come we're trying and trying and trying and nothing is working? And I'm going to try to walk you through some thoughts, okay? This is a broad topic, but I'll try to focus on some things that I hopefully will be of interest for you. I'm just going to walk you through a little bit what the medications are targeting, okay? The first thing I want you to look at is here on the right on the right bottom, acetylcholine, all right? In the brain, we have many different kinds of chemicals, of neurotransmitters. One of them is acetylcholine, and this acetylcholine is low in Alzheimer's disease brains. So there are 4 medications today in the market to treat Alzheimer's disease, and 3 of them, their job is to increase the amount of acetylcholine in the brain. The 4th one has a different mechanism. Those 4 medications have very limited effect, okay? They're all FDA approved. They delay a little bit the symptoms, but eventually the course of the disease goes back to where it was before, okay? And the other major pitfall that those medications have is that they have an effect on 30 to 40% of the people who take them. And we have not been able to identify who those people are. So let's say we try to see if men or women react more. No. Certain genetics? No. Certain backgrounds of diseases? No. Earlier versus later age? No. But there is something that allows certain people to react to them and make good use of them a little bit, even if their efficacy is limited and others don't. By the way, the solution is to treat everybody and to hope that the particular patient gains something out of it. So this is a main area where medications in the prior decade were being developed. In the last decade, most of the medications that I mentioned before have been focused in developing other or focusing on other targets. I want to introduce you to this upper left little slide called amyloid plaques, okay? Those yucky brown things here. Those are aggregates of a particular protein called amyloid. It sits between neurons, between the nerve cells in synapse, in the little gap that there is between them. In the picture here, you can see that little gap. This is where those amyloid plaques sit. And when those neurons can't talk, both of them die, okay? The second and this is very prevalent in the brain of an Alzheimer's patient. The second pathology is called neurofibrillary tangles, and it's actually inside the neuron. The first one I said it's in between the neurons. This one is a protein that holds the body of the cell intact. And for some reason that we don't know, this protein, it's called tau, which produces those tangles, stops functioning, and the body of the cell collapses and the cell dies. And then it goes from one cell to the other and progresses. So those are 2 areas or 2 targets that medications that are being developed are trying to address, okay? To break down the amyloid plaques and break down the tangles. This, by the way, is a slide from our group, which is a very cute slide. This way I put it on. So those called microglia. Microglia are the defense cells, the immune cells of the brain. Very, very tricky and very intelligent cells. And what you see here is real. They are very well working microglia. And those orange patches are actually amyloid plaques. And as you can see, the microglia gets activated and chops it. This is what happens when everything is okay. In Alzheimer's disease, this function, or the way the microglia functions, stops being good or stops being the way it should be, and then it cannot break down amyloid in an effective way. So then I'm going to go back, now that you have a feel, I'm simplifying it for obvious reasons, but you get a feel of what are the different biological targets that the world is trying to address in terms of treatment for Alzheimer's disease. And then I want to go back and ask again the question, 460 medications didn't work, why? So the very first answer is nothing in the universe, nothing compares to the complexity of the brain, okay? So in that way, I'm being a little soft, right, with the scientific world, because the brain is extremely complex, and it's good enough of a reason for us to have more failure than in heart and skin and intestines. Now let's think about specific things that are happening in the Alzheimer's world. One thing is heterogeneity. And what do I mean by that? When we do a clinical trial and test the medication for Alzheimer's disease, the majority of clinical trials bring 6,000 people, 3,000 get the medication, 3,000 get placebo, and that's it. And they don't take into account what is the genetic background. Now think about what happens in the world of breast cancer. In breast cancer, you test what genetics of breast cancer the woman has, and you adapt the medication to that genetic background. All right, there are, I think, 76 or 78 different protocols for breast cancer treatment that account for that genetic background. So this is something that we're beginning to address. The second issue is that maybe we're not hitting the right biological target. So I showed you a few of the targets. And if you notice, those targets are palpable targets, right? There is a plaque, there is a tangle, there is a synapse that you can see, right? That little gap between two neurons. But the reality is, as I said, that the brain is so complicated, and there are connections between different areas of the brain and pathways of neurons and different kind of movements of proteins that might be affecting the neurodegenerative process. And as you'll see at the end of my presentation, this is a direction to take that might be more complete than looking at one single pathology. And then there is a third explanation for our failure so far. And this is a major area in our research, okay? And I'll show you the next graph. But the point is, we might be treating people far too late. This graph is a data-based graph, okay? This is not a conceptual model. The line at the bottom is the line that represents that age graph that I showed you before. So you can see that clinically speaking, at the age of 60 something, you'll see about 4 or 5% of people with Alzheimer's disease. And the age of 85, you'll see about half, okay? Now the hard black line is amyloid pathology. And if you see this red arrow here, what this red arrow is telling us, that the pathology begins aggregating in the brain 20 to 30 years before the first memory impairment, as is measured today, shows up. This is critical, okay? We're treating people at their 70s, and their disease in the brain started 20 to 30 years earlier. So age, sex, and genetics are non-modifiable risk factors, mostly speaking, okay? We can't yet change them. Age is a question mark because there's a lot of research on aging and how to stop the aging process. But generally speaking, we can't stop age. We can't change the basics of the biology of sex, and we can't change genetics per se. We might be able to change what the gene does, but not the gene itself. And here are 7 modifiable risk factors that have been consistently associated with Alzheimer's disease. So low physical activity, or couch potato if you prefer, obesity, hypertension, diabetes, smoking. Those are all also related to heart disease, right? Remember, those 5 that are bad for the heart are clearly bad for the brain. And then there are 2 that are specifically related to the brain, which is poor cognitive activity. So active cognition, reading newspapers, debating, playing, studying, going out of your comfort zone and making a cognitive effort seem to have value. And depression. Depression is a very complex story in terms of Alzheimer's disease, but people with depression have a higher risk of developing the disease. If we have time, I can detail some more later on. So at this point, there are 3 major clinical trials that have been published in the literature, but there's several others trying to replicate. And pay attention to what I'm going to say now. Those clinical trials are suggesting that if you attack those risk factors, everything that is bad, you make it better or not have it at all. So no diabetes, no hypertension, or if you already have them, controlling them perfectly well, improving physical activity, improving cognitive activity, and so on, controlling depression if there is. If you do that, the rate of cognitive decline, this is data, okay? Those clinical trials, the rate of cognitive decline over time is slower. Now think of it theoretically speaking, that if this clinical trial would have gone on and on for 20 years, we might have seen, if we extrapolate, that Alzheimer's disease was pushed away by 10 years. And if I have to choose between having Alzheimer's at the age of 75 or 85, I have no question mark. I'd rather have it later. All right. Now, this is very important because I just showed you that 460 clinical trials of medications did not work out, while clinical trials for lifestyle change is making a difference. Why is this very important? Because people want pills. People want that super cool, hyper duper Superman pill or superwoman that has the capacity to stop your hypertension, your diabetes, make your body feel as if it exercised, and obviously make you happy and not depressed. But what I'm showing here is that there are alternative ways that might work to your benefit. By the way, I thought it was a little early, so I was a little bit surprised, but the World Health Organization actually came out with dementia prevention recommendations. And if you have an interest and you go in, the document itself is huge, like 170 or 180 pages, but they have a summary of a few pages. So you can see what are the different risk factors. The number one that they address and that they show more stable data is physical activity. And this is their website, the WHO website, in case you have interest. So now we have a major scientific goal as a group, okay, as a scientific group, based on the little story I told you so far. We want to find technologies that can identify the very earliest steps of the disease, and in parallel, the first biological changes underlying those cognitive changes. Now, why is this important? And I'll clarify in a moment. But the main issue is that graph that I showed you, because the point is to intervene in the best window of opportunity that seems to be 20 to 30 years before the disease shows up, which is then when the pathology is developing. So we developed an Alzheimer's breakthrough program. It's planned, right? And again, it has two parallel pathways. One is defining the earliest biological changes of Alzheimer's disease. And the second is defining the earliest behavioral and cognitive changes of Alzheimer's disease. Now, at this point, if I was face to face with you guys, you might have stopped me and asked, wait a minute, you're telling me you're going to discover with mega technology, which I'll exemplify very excitedly very soon, that you can discover when I'm 42, that at the age of 75, I will develop Alzheimer's disease. What is the point of me knowing such terrible news, if there is nothing to do for me yet? Because as I said, medication, a pill, we don't have. So I want to say two things. The first and most important thing, every person has the right to know or not know. The person has the right to choose if he or she wants to know. I'll tell you an anecdote that might be of interest to you. There are ways of measuring today amyloid in the brain. All right. And today, the way we measure amyloid in the brain is using PET scan. We have to inject a certain material that has radioactivity, it goes up to the brain, it recognizes amyloid, it shines in the PET scan, and we know if the person has it. In the world, people are not being told if they have amyloid, all right? Because we don't have medications yet. Exactly the question of what can we give them? In Israel, we're the first, by the way, I'm going to say many times we're the first, and it's all true. We're the first to do amyloid imaging in Israel. I think we have over 200 people scanned. And we tried. I said, okay, in the world, people don't give the answer. So we don't give the answer. Guess what? In Israel, that doesn't work. If I don't give the answer, nobody will come to the scan. So we had to go into our ethical committee and ask special approval to give the answers, and all patients know the answer, okay? Now, why I think it is important, I don't know if it is important to know, but if a person chooses to know, what are the little advantages that that person has? The first one is the prevention program that I just showed you. There are preventive measures that are growing in terms of the amount of evidence collected, suggesting that if you adopt them, your rate of decline will be slower. That's number one. Number two, we're all running after prevention medications. So there are clinical trials for non-symptomatic people that are at high risk. And all my patients who are amyloid positive, in the minute a new clinical trial arrives for people at high risk, but with no symptoms, they're the first to be invited. The third thing is the third issue is obviously the opportunity to plan, to say, if this, then I want that thing being done financially, in terms of family, whatever. And the fourth thing is, the fourth issue is mainly a scientific, but it has a clinical value. There is no point for me to know what those biological very early changes are. Not that there is no point, they're meaningless if I don't know what they mean in terms of the cognitive outcome. It is not going to help me to know that a certain biology changed if I don't know how it affected the way my brain thinks or remembers. And this is why those two pathways have to go all the time together. So now I'm going to give you examples of 3 technologies that we're using for very early ascertainment of disease, okay? Now, I want to take a few minutes to talk about RETSPEC, and for 2 reasons. The first one is because Eliav Sheked, who is the CEO of this company, he is actually, I think, I know, I've seen him. He is in the audience, and I think Catherine also, who works with him, is there as well. I should emphasize that I have 0 financial conflict of interest with any of the companies I'm going to mention. I do have love conflict of interest because I love those guys and I love working with them. And so I said 2 reasons. One is because Eliav and Catherine are in the audience, but also because this company is running in Canada. They're all in Toronto. So this is good for you guys. And what they're doing is quite remarkable, okay? They are developing a sophisticated camera that is able to identify the very first stages of amyloid, the very first stages of aggregation of amyloid in the retina. Now think of it this way, the retina is a protrusion of the brain, okay? The retina, the eye is a part of the in fact, the only part of the central nervous system that is exposed to the world, right? Everything else is inside. And the retina, because it's a protrusion of the brain, it has many of the characteristics of the brain, and it does aggregate amyloid. This technology is able to identify, it's still being tested, okay? But is able to identify amyloid in the brain, the beginning of the aggregation. This graph here on the right, without getting into too much numeric detail, is essentially saying that this technology, by the amount of amyloid it's seeing in the retina, is able to differentiate people with normal cognition from people with mild cognitive impairment. Now think of it this way. I told you that we have a way of measuring amyloid in the brain today, and we need a PET scan, and we need to inject radioactive material. Because of that, we cannot do it every 6 months or whatever time we want to do, et cetera, et cetera. So we are desperately looking for technologies that allow us to see the progress and evolving of the pathology over time, okay? And this is what RETSPEC is doing. They, in their hands, they're working with data we have collected on, I believe, 84 people so far. And together with RETSPEC, we received, and a group from the University of Minnesota, we received a Bill Gates grant to continue doing this research, which now that our institutional review board approved that we go back to seeing old people, will begin doing. This is another technology called MindU. They're Israelis, but their business is in the US, so they moved to New York now. So they'll come back, And this is a completely different idea. They're looking at, they're using sensors off the cell phone to collect every possible piece of information they can about your cognition and behavior. For example, okay, they collect information not about content, no content collected by them, but about your voice, your fluency, your pitch, your intensity, and so on. And it's continuous. As far as your phone is next to you, it keeps collecting information. Using other sensors, it collects information about your reaction time, collects information about the amount of space you use in your regular day-to-day. And theoretically, if we follow up patients over time or individuals in general, that algorithm is going to tell us that everything is as usual, and maybe not as usual. And then when it's maybe not as usual, this is when we have to kick in and say, wait a minute, something is going on, let's check the person. Now, remember that those are so sensitive measures that the naked eye or the best hearing doctor in the world will not be able to grasp it. Now, this graph on the left is a real patient and a 1-year data through the information that was collected. The larger the number, the more difficulty the person has. And this is in this case, and this is what we're seeing here, that this person is becoming demented more and more over time. And the graph on your right is essentially showing something very cool, that there is a nice correlation between a 1-month data collection with this technology on the phone and the size of your hippocampus. What does it mean, size of your hippocampus? Hippocampus is a little region in the brain, more or less at the height of your ears inside, okay? And it's the first region affected by Alzheimer's disease. It's a main region responsible for memory, okay? The pathology of Alzheimer's disease loves sitting there. And this is why memory is the first cognitive domain affected, all right? And what we're showing is that, think of it, a cell phone, a cell phone-based algorithm that is collecting data about things related to your behavior, reaction time, amount of space you use, the fluency of your voice, has to do with the size of your hippocampus. Now you understand where we're trying to take this, right? Because if everybody's on this technology, assuming it's gonna work, remember, these are all novel technology that has to be tested more and more. But assuming that those are gonna work, then over the years, you have a very clear, smooth pathway of what the person's, of the normal state of the person, until in some people, it's not gonna show normalcy, and then we have to wake up. And finally, on the piece of the very early ascertainment, I wanted to show you another side. Each one of those are so cool that I could keep going and going. And yet, let me give it a try here as well. So this is something that we're doing and developing here in Sheba, and my friend and colleague, Meir Plotnik, is responsible for all the virtual reality here at Sheba. And the amount of cool things that we do there is unbelievable, and it's so much fun. I literally feel that I'm in Disneyland every time again. But what you can see here is this little dude here, and he has a head mount device. This is a virtual reality glasses, okay? He has a controller. So now remember this, I'm gonna take one step back. This is a little test called Trails Making Test. It examines your simple attention and divided attention. In paper and pencil, which is what we're still using for clinical trials around the world, the person has little circles all over the page with the, let's say, the letter A and the number 1 and the letter B and the number 2, and the person has to go A, 1, 2, B, 3, C, etc. And it has to do in a particular way, okay? We count the time, we count the amount of mistakes on the paper, which is most of what we can do. When you move to virtual reality, I can count everything. I can really understand the whole behavior, because in virtual reality, the person is seeing this and doing it 3D, so we can see the amount of movement, the amount of effort, the time of effort, the sophistication or simplicity that a person is getting from one point to the other. And then we add to this other sensors, for example, for heartbeat and other things, to see if the amount of stress the person has while trying to resolve a problem is contributing to his capacity of doing it well or not. So this is something we have been doing in Sheba, and now you understand why. As I said, the world is using primarily paper and pencil tests. Now here we compared our virtual reality trails making tests to a paper and pencil. And what we show is the following. Those are old people, those are middle-aged people, and those are young people. Generally, you don't have to understand in depth the graphs. I'm going to walk you through them, but what this is telling us mostly is that older people are a little slower than younger people, surprise, and that older people do a little bit more mistakes than younger people, also, haha, surprise. But why is that advantageous? Because we see that this happens more when you're using the virtual reality. Why is that important? If you have more errors and longer period of times for the person to get it right, you get a broader range of capacities. Some people will be able to do it very, very quickly and well. And some people have a very, very difficult time, and everybody else somewhere in the middle. When you have a broader range of capabilities, then that tool becomes more sensitive of catching disease. So this is just an example of how virtual reality can be used to improve very early diagnoses. So now I'm going to move to the second pathway. All right, remember this way. The first one was the very early ascertainment, which I told you is essential because that's where we believe the window of opportunity to treat people effectively is. Yeah, Einat, how am I doing with time?
I think we need to wrap up soon for questions.
Okay, so I need some 5 minutes.
Okay, sure.
Okay?
Yeah.
Okay. So I'm going to give you an example of things that we're doing at Sheba with regard to the earliest biological alterations, okay? I promised to brag a little bit and say that once again, we were the first to discover that a particular gene called haptoglobin among diabetics, it's a very interesting gene and it does a lot of bad things to diabetics and it does almost nothing to non-diabetics. But among diabetics, which in the United States is about 30% of those above the age of 65, the people who carry a particular genotype called the 1-1, a particular type of that gene, they have lower cognition, all right? They have a smaller hippocampus. And a student of mine in New York, whose name is Elizabeth, who is Black and Hispanic, and she says, and I'm a woman, so I'm a complete knockout. She's a triple threat. And she's very interested in minorities. And she said, Michal, I can see that among Black people, there is a 30% 1-1s, which is more than double than what there is in white people. Now, here's the interesting fact. Black people have more prevalent Alzheimer's disease than white people. So we're now, through this paper here, we actually investigated, think of it, we discovered something in our Israeli Jewish community, and we translate it to the Black community in the world, all right? This is very exciting for me to know that something that we discover has the potential to help very broad, let's say, very broad population. In any case, I'm going to very quickly, because I understand I'm finishing my time, I'm going to introduce you to how we want to address the issue of the gene, okay? I told you before, we can't really change the gene yet, maybe one day, but we can try to understand what is that gene does, and I'll relate to that in a moment. The way we're working at the center now in Sheba is that we are taking all the information about our patients, including their bloods, and we are running something called omics. All right, you might have heard the word genomics, but there are many other omics, transcriptomics, proteomics, metabolomics, lipidomics, etc. Omics is actually a technology that has been developed that with very little blood or very little brain tissue, you can learn about the whole proteome or the whole genome. Now think that if once we would look at one protein or one pathway, today we look at the person as a biological system, which of course is much more realistic. We're not one protein, we're a gazillion proteins. In relation to that haptoglobin gene, we went with a group at the Reisman Institute, we're collaborating, and we looked, since they're diabetic, proteins, many proteins, they have a glucose molecule that is attached to it. When this attachment has functional meaning, the protein is going to work one way or the other according to how that molecule of glucose is going to affect it. What we have been able to show with this omics technology is looking at the full glycoproteome of our participants and to show that there is a change in the glycoprotein for those who are declining over time, which is not happening for those who are stable. Now we're in the beginning, we have to replicate it, we have to do it with larger numbers. I mean, there is a lot to do there, but just for you to conceptually understand it, we're onto something. By the way, now we're checking it on a sample of Black people because I think they may have a better chance of gaining from it. But the main point here is that we are onto something that is not one single molecule or one single protein, but a series of changes that started with that gene that we realized is doing trouble. And now we're trying to understand what is the biology that gene is affecting to be able to change it. And hopefully those who are going down will not go down anymore. We have a long way, but that's the direction. So I'm just going to finish with a slide that I always put as my last one because I love her. And her name is Madame Jean-Louis Calment. And she died at the age of 122. And I believe there is a 125 years old Japanese woman that died a few years ago that is older. She broke this woman's record. She started fencing at the age of 85. She biked until she was 100. She smoked 2 cigarettes until she was 117. And often I ask myself, or others ask, what went through her. But at the age of 117, she decided she should stop smoking. She drank port wine every day. And the one that I most adore her for, she had 2.5 pounds of chocolate per week. That means a pack of chocolate every day. And she died, that's the most important point. She died cognitively intact, okay? And this is where we wanna go. Thank you.
Thank you so much, Michal. I'll give it away to Daryl to moderate few questions.
Thank you, Michal. That was amazing, fascinating talk. Wish we had hours more to delve into some of the things that you mentioned today. So I'm going to ask you a couple of questions that came up on the chat. You talked about modifiable risks, that if we do exercise, if we manage our coexisting medical problems like diabetes, then we may be able to slow down the development of Alzheimer's or dementia. Are there specific foods or supplements that might slow down the development of dementia or Alzheimer's?
Okay, so this is a question that often comes, and for good reasons. The issue, I have to say, eventually I fall into nutrition as well, into research of nutrition, because we can't live without it. It's perhaps the only thing that we can't not do, right? And it's so complicated, all right? I'll give you a reasonable answer in a moment, but it is very, very complicated because what we put in our mouths has to do with how Jewish of a mom we had and how much she pushed the knedelach or whatever into, or the milk or whatever into our mouth. And if we were teenagers and we were hot or not hot and how much people thought we were beautiful or not, and then we decided how much we're going to put in our mouth. And then how much women gain weight after having babies, and how much men build that belly because they were depressed at the age of 40, that half of their life, now less than half their life is gone, et cetera, et cetera. So there is so much going on in addition to genetics and family history that it becomes very, very complicated. And yet, I want to say the following. The research on specific nutrients had essentially no results, okay? So it's research on omega-3 solely, or on vitamin E alone, or on B12 alone. The results were nothing. Now there is a problem with that. It might be because when we look at one nutrient, it doesn't represent the whole pattern of eating we have. That's a good reason for a failure of such a clinical trial. But there is another reason that is somewhat problematic, okay? For a person to take advantage of a nutrient, that person has to have low levels of that nutrient. Now, if a person has low levels of that nutrient, you cannot bring them to a clinical trial and say, you have low vitamin E in your blood, but we're in a clinical trial. So half of you are going to receive vitamin E and fix that, while the other half is going to continue having low levels. That became a problem, okay? But generally speaking, so we have an ethical issue with dietary or with nutritional clinical trials. That said, the clinical trials on patterns of eating, primarily Mediterranean diet, and I know it sounds like a blah, blah, but if you go in PubMed, you'll see it, okay? There are several serious clinical trials showing that people who maintain the Mediterranean diet over time, their cognitive decline is slowed.
Okay. And the next question, is there new research looking at the impact of CBD on Alzheimer's symptoms and progression? CBD is all the rage now, and being access to cannabis is more and more easy to get. So your thoughts?
So it is a complicated matter, and I'll tell you why. The level of CBD, as far as it's not synthetic, changes with every crop. Okay, so if you have one clinical trial, you have to use the same CBD, otherwise people will be getting different levels or different intensities. That said, I don't know of literature for prevention. The literature on treatment is divided. Nothing on cognitive improvement, a lot on behavioral improvement. And I should say that 80% of Alzheimer's patients at some point of their disease will have severe behavioral issues, from paranoia to inappropriateness, sexual statements in inappropriate situations, and up to psychosis, all right? And it seems that CBD has some positive effects on people with behavioral disturbances due to Alzheimer's disease. That said, if you speak, and now I'm not talking about clinical trials per se, but if you speak to physicians who care for Alzheimer's disease patients, there is always someone who's going to tell you that they treated someone with CBD hoping that it will improve their behavioral disturbances and that it made them psychotic. So there is tons of research to be done. There are technical issues that have to be taken care of, and it has to be with great, great care, because there are at least anecdotal instances of psychotic episodes due to CBD.
And you talked about exercise as being preventive. Specific type of exercise, cardio versus resistance training? Is it heart rate? What kind of exercise should we be doing to slow it down? Okay,
so generally speaking, if you look at overall at the literature, you will see that physical activity that is aerobic is more beneficial or shows benefits compared to physical activity that is anaerobic. That said, muscle is a wonderful insulin sensitizer. Okay, when you have more muscle, you have more insulin sensitivity, lower risk of increasing glucose levels, maintaining your body, getting rid of or getting glucose into the cells appropriately, not becoming hyperinsulinemic, which eventually will lead you to diabetes. Coincidentally, I'm reviewing now for one of the institutions, I can't say the name, okay? And I just read an application that they're now comparing aerobic physical activity. I don't know the answer yet, by the way. They are about to do the research, so it's going to be interesting. But they're comparing aerobic physical activity, moderately aerobic physical activity, to very intense but short physical activity. One that makes your heartbeat go very high and then go down, and then 3 times a week. I don't know what's going to happen there. But what is important here is to remember that the pathways through which physical activity, primarily aerobic, affects beneficially the brain are very logical, okay? It begins by your vessels being clearer, right? So it begins by your cardiovascular disease being, or cardiovascular condition being better. It goes through faster cerebral blood flow and clearance of toxins through the cerebral spinal fluid. It does release more neurotransmitters that make neurons develop more connections, such as the brain-derived neurotrophic factor, BDNF. So there are many reasons, many different mechanisms through which physical activity can affect beneficially the brain, and everybody should be exercising.
Okay, and you talked a lot about technology to sort of advance our knowledge around dementia and Alzheimer's. What about technology that we use day to day? Is there any research that shows that relying more and more on our technology, like our cell phones, computers, etc., has any impact on the brain. For example, we call people on the phone, we don't dial in their number, we just, press, Michal.
Right. So there is a whole debate about this. And I'm not familiar with literature on older adults, which would be of interest to me. I think we probably need to wait a few more years to see the coming generation that is getting into older age and see what's going to happen. And we do have to remember that it's true that on the one hand, you press Michal and that's it. And on the other hand, you have to process an enormous amount of information that in the past you didn't. So there are give and takes in that. I do have to say that in children, there is literature on exposure to video games and to cell phones, and literally decreases in function in certain areas of the brain. There's some very nice studies that follow children for 5 years. So in doing developing, that might not be the great thing. In old age, I don't know yet.
And you used a couple of terms that someone asked to clarify. You talked about memory and short-term and long-term memory, and where is it located in the brain? But can you also distinguish between cognitive abilities and memory? Sure.
So first of all, and thank you for asking that, because we talk as if, right, that's our jargon. So first of all, short-term memory, so sometimes I joke and I say, let's say someone calls and it tells you, please write down my phone and call me back. So they give a phone number, 201-894-8748, whatever. And the person turns off the phone and your phone falls on the floor. What happens then? Forget, right? I always say that's the phone number of my mother-in-law. That's my joke. I forgot the phone number of my mother. But that short-term memory, which didn't make it through the hippocampus and therefore didn't sit down well in the brain, that's the first one to go in Alzheimer's disease. And this is why people can be asking again and again. I have a patient in the US whose ex-wife seemed to have the same curls as me. And when he sees me in 1 hour, he can ask about 150 times, oh my God, you have the hair of my ex-wife. Just in different ways, he'll say 150 times, zero short-term memory. Long-term memory goes away later, and it includes, and many times families come to us, by the way, and say, I don't know, he's not remembering what he had for breakfast, but he can tell you who was his teacher in first grade, okay? Those are more robust, takes longer time, but eventually they go as well. So this is in terms of short-term and long-term memory. Memory, cognition is a mother name for many cognitive capacities. Memory is one of them. And memory itself is divided into short-term and long-term, semantic, episodic, procedural, so very different types of memory, which are located or activated in different areas of the brain. But there is also, as I mentioned before, orientation in space. Look at that lady already running. I lost my track, that's it. So orientation in space, orientation in time, there is attention, there is working memory. And within executive functions, there are 10 different types of subtypes of cognitive functions. So cognition is a grand name for many different types of cognitive functions, and memory is one of them, and the first to be affected by Alzheimer's disease.
So we're getting close to the end, and I'm going to ask to tie into the cognitive activity piece as the final question. Someone asks, what is the best cognitive activity that you can do? And does using an application on the cell phone help? And are there any apps that you would recommend?
Okay. So we actually have a few studies on this. So I feel quite strongly about what I'm going to say because it's data that I've seen in front of my eyes, okay? We use different softwares that are in the market to compare to nothing, compared to playing video games, things that are not directly intended to improve cognition. Overall, our conclusion is the more you work it, the better, all right? In other words, what I always suggest, and I have to tell you, I do this for my mom and I'm doing it for myself as well. Wherever is a comfort zone, get out of it. All right. So now I'm learning Italian. Why? Because it's a new language, and still I'm being let's say a little bit lazy with my brain because I'm a Spanish and Portuguese speaker, so Italian comes easier to me. But I said I need to learn a new language. Not too long ago, or when life was normal, a lady came to me and asked if it is possible that at the age of 72, she started studying piano. If I think that has to do with the fact that she feels that her memory is sharper. I can't measure and say that's the case, but she subjectively at least feels that this whole new world of intellectual effort that she's making is doing something for her. So there isn't good enough data. There is not good enough data, but the data that we have in our hands and also others, it doesn't really matter what kind of software or app or whatever intellectual effort you're making, just make it and out of your comfort zone. Wherever it's comfortable, this is where you don't want to be. You want to make an effort. Sweat your brain.
Thank you very much, Michal, Professor Beeri. It was fascinating. We have so many other questions on the chat, and I really open it for everybody to feel free to email me or any of our people at Canadian Friends of Sheba. We will be happy to try and answer and address it with Michal, if she will agree. And for sure, we would love to have you again in the future, maybe in person. Just to announce to everybody that our next big event will take place in May 2nd. It's going to call, like, really a cool name, Sheba Under the Stars. And you saw one of the stars from Sheba now. So stay tuned. We welcome everybody to join us. On this particular event, we will bring some hope and comfort to your home. It will be focused about wellness and lifestyle, so I can connect to what Michal just mentioned. Eating well, exercising. You will hear from top Sheba's experts, and we will follow with a wine tasting and a real star performance. You will hear valuable tips on how to combat the pandemic, anxiety, and stress, which we all live in for a year already. On behalf of the entire Sheba Medical Center family, we look forward to your continued support and seeing you soon. Can't wait to the next event. So thank you so much, Professor Beeri. It was fascinating again. And Dr. Daryl Reisman, our chair, and for hosting the questions. And I wish you a great Sunday. Enjoy the weather, and thank you for joining.
Bye-bye, everybody.
Thank you.
Michal, well, oops, we lost her. Okay.
Is Michal gone?
I think so.
Can you just pass on a big standing ovation for her? Because that was tremendous.
We will.
Thank you.
She was amazing. She was great.
Thanks, everybody, for joining.